Okay, here we go. Management of patients with chronic pulmonary diseases. We're going to specifically look at chronic bronchitis, emphysema, and we're discussing asthma as well in block 1. Chronic obstructive pulmonary disease is a slow, progressive respiratory disease that literally deals with airflow obstruction and for different reasons, and we'll get into those. Again, talking chronic bronchitis, emphysema, and asthma. These are preventable, but if patients get them, they are treatable. But again, chronic bronchitis and emphysema are not fully reversible. They do involve the airways, the parenchyma of the tissue. It is the 4th leading cause of death in the United States, COPD, with patients of all ages. And the other chronic pulmonary diseases we're going to look at specifically is bronchiectasis, asthma. Well, we talked about asthma up there, but cystic fibrosis, right? And I did talk about cystic fibrosis in the other video, so I'm not going to mention much about it here. So what is the patho behind COPD? There is an airflow limitation that is progressive in nature, meaning it gets worse over time, right? It's chronic. It's getting worse over time. And with this airflow limitation, it's literally associated with the inflammatory response that's happening in the tissue of the lungs, right? And this inflammatory response is in responses to noxious particles or gases that are occurring in the body and in the environment, right? Chronic inflammation occurs over time with these patients, and as a result, the tissue is damaged, right? Scar tissues in the airways results in them narrowing, and scar tissues in the parenchyma decreases the elastic recoil in the lung tissue. Scar tissue also in the pulmonary vasculature causes thickening of the vessel lining as well as hypertrophy of the smooth muscle. So patients end up getting pulmonary hypertension, right? Which we talked about when Marcel did cardiac. Okay, chronic bronchitis. So the difference between acute I want to say one of the differences between acute bronchitis and chronic bronchitis. So patients can have an acute bronchitis event where they end up going into their doctor with, an episode of cough and sputum production, where their ciliary function's reduced and their bronchial walls thicken, and they get their, narrowed bronchial airways and mucus plugs, and they're having problems with all of that, right? So the doctor or provider will treat the patient for that acute event. Then they'll go, a couple years, and then they'll have another acute bronchitis event. They don't get diagnosed with chronic bronchitis, which is one of the COPD. It's under the bigger umbrella of chronic obstructive pulmonary disorders, right? Chronic bronchitis is one of them that we're going to talk about in block 1. They don't actually get diagnosed with chronic bronchitis until they have been to the doctor, their provider, for at least 3 months in 2 back-to-back years. So basically saying they have to have come back to the doctor multiple times to be treated for an acute bronchitis event, and the doctor therefore says, we are no longer acutely describing this, it is now chronic because you have been in here multiple times this year for the past 2 years, and we can no longer say it's just an acute event, right? So again, when we're looking at that, we're looking at the ciliary function is reduced because the bronchial walls are thickening and the bronchial airways are narrowing, and therefore the mucus is getting stuck in those airways, right? Over time, the alveoli are being damaged, right? Remember, the alveoli is the most important structure of the lungs, right? They're getting damaged, fibrosed, and their alveolar function diminishes over time, right? Patient is more susceptible to respiratory infections, much more. Here is a picture of what your normal lung tissue looks at on the left, right? So you have your smooth muscle, then the open airway. You do have your mucus gland that goes all the way across, right? And then when you're looking at chronic bronchitis, look at that. Look at the inflammation. Huge. And it causes an increased number of mucus glands to be stimulated and activated, thus producing more excessive mucus, causing chronic cough, right? That's a beautiful picture. Okay, so clinical manifestations of your COPD patient, right? 3 primary symptoms. You're going to have a patient's going to have a chronic cough. They're definitely going to be producing tons of sputum, and it's definitely that inflammation. All those variables are going to lead to dyspnea over time, right? And they are going to lose weight due to the dyspnea, right? And, because there's so many factors that leads to the weight loss, but one of them, think about it. If you get tired eating 3 to 5 bites of food because it's exhausting as a COPD patient to do anything, you're going to stop eating, right? Because already we know that as we age, not to say that there aren't young people who get COPD, because there are, but we know as you age, more and more people will end up with COPD, right? We know that the elderly's sense of hunger diminishes, right, over time. And their taste buds diminish over time, right? So if it's too much work, they're just not going to do it, right? Because remember, airway, breathing, circulation is priority. And if your patient can't breathe, they're not going to care to eat, basically. They also end up what's called the barrel chest. I have a good picture on the next slide of this, which is the increased anterior to posterior growth of the chest, right? So when you're looking at that barrel chest, that's the picture on the right, you literally have that increase in the anterior posterior diameter. So your patient on the left is normal, and then you'll notice that your anterior posterior to your transverse, right? So your patient's anterior posterior should be 1, and their transverse is 2 times the size of the anterior posterior on a normal patient. When your patient has COPD, chronic bronchitis, they end up with this barrel chest, meaning their anterior posterior is now double its normal size, and therefore it is literally the same as their transverse, right? So when you're looking at your patient head on, is now the same size as when you're looking at their side view, right? And that is literally due to the hyperinflation of the lungs. The CO2, the carbon dioxide, gets trapped in the lung tissue, causing the lungs to fill up with CO2, which literally pushes on the lung tissue, pushes out on the chest wall, and the patient ends up getting this barrel chest. All right. Okay, so this is looking at the alveoli and what happens when a patient has COPD. This is great. So you're looking at the healthy lung tissue. You look at the little grape-like clusters. Oh my gosh, they put faces on them. How cute. Sorry, I digress. But they have grape-like clusters on the end of the bronchial trees, and you have a great amount of alveoli to do carbon dioxide and oxygen exchange, right? So you get your tissues oxygenated. When you have emphysema, you get these collapsed airways leading to collapsed alveoli, which is terrible. And then with chronic bronchitis, what you get is the mucus buildup in those airways with the tight, smooth muscle due to that inflammation, right? Causing narrowed airways. So not only are the airways narrowed, but now they also have all this excess mucus. And we know that CO2 and oxygen don't go through mucus, right? Okay, so this is the kyphosis that we talked about earlier in this lecture and the other lecture as well, that a person, typical posture of a person with COPD, right? So there, that's a picture on the top left as well as the bottom left. And again, so what you see, this patient in the middle on the left and on the right are what we call tripoding. Okay, so that's a position where they sit up and they literally lean forward. Sometimes they use their bedside table, and it helps expand that lung volume there, right? Thus allowing them to breathe easier. So tripoding is what that's called. So I would remember that. And again, they naturally can breathe better like that. So even if we haven't educated them on that, a lot of them have figured it out. But it is our job to show them how they can breathe easier, right? By tripoding, whoops, my apologies, touch screen. By tripoding, it literally decreases their work of breathing, right? By allowing the greater chest expansion, therefore greater lung expansion, and therefore their ability to use their accessory muscles improves when they tripod. So we definitely want them doing that, okay? Okay, let's see. Okay, so assessment and diagnoses of COPD. So clearly we're going to get a full health history, right? We're going to look at things like, you know, did they smoke? Did they work in an industry where they were exposed to chemicals or dust or any kind of artificial means of, you know, causing lung damage and stuff like that, right? We're going to look at, do they work out? Do they eat healthy? All of those things, right? Genetic factors, right? We know that there's a genetic component to the antitrypsin. It's an enzyme, right? So if there's a lack of production of that, that can lead to lung tissue, all kinds of things, right? So we're going to get a full health history. We're going to order, the doctor will order pulmonary function tests that we talked about in the other video. I'm not going to cover here. We'll look at spirometry. I talked about that as well. I talked about arterial blood gases as well as chest x-rays. So we're going to get all of these diagnostic tools to help the provider narrow down exactly what is occurring with the patient, right? Complications of COPD, we know that the respiratory is insufficient due to the lung tissue damage and can lead to failure over time. We know that fluid will build up when it does. You know, in the lungs, it's a warm, dark, warm environment. What better way for bacteria to grow? So patients will end up with pneumonia. It can cause atelectasis, pneumothoraxes, and cor pulmonale. Okay, so atelectasis is the collapse of one or more parts of the lung, but not the full lung. So atelectasis is a partial collapse of your lung. Pneumothorax is when the entire lung collapses, okay? And so when we breathe in, your lungs will fill up with air. The air travels to the sacs in your lungs, or the alveoli, right, where the oxygen moves into your blood. The blood delivers the oxygen to your organs and tissues throughout the body, right? And if you don't have enough air coming in to inflate your alveoli, or if the outside pressure is pushing on them, then they can collapse, right, causing atelectasis, or if it's the full lung, pneumothorax. And if your lung is affected, your blood may not receive enough oxygen, which can cause major health issues, right? So again, how does COPD cause that? Well, we know that atelectasis, again, happens when the lung sacs or the alveoli can't inflate properly, and that is due to a blockage, low airflow, or scarring. And we already talked about how COPD can cause scarring and a blockage, right, due to the mucus. So you can see how whether it is emphysema or chronic bronchitis, it can lead to chronic atelectasis or even pneumothoraxes, right? And then we have cor pulmonale, which we talked about when we discussed sided heart failure, right? That's cor pulmonale. So when Marcel talked about the cardiac, we discussed it. But with COPD, it is, first of all, COPD is the leading cause of cor pulmonale, okay? So it happens when low oxygen levels due to COPD cause a rise in blood pressure in the arteries of the lungs, right? And so it leads to pulmonary hypertension. This increase in pressure places excess strain on the heart's right ventricle as it works to pump blood through the lungs, right? And so leads to cor pulmonale. Make sense? Okay, so medical management of COPD. So we are definitely going to talk to our patients about smoking cessation, stopping smoking altogether, right? We're going to speak to them about things they can do to reduce risk factors, right? So try to, I know this is hard, but try not to live in an area where smog is a big problem, like those large cities. Don't smoke, don't vape, all of those things. Lose weight, work out, all of those things, right? Stay hydrated, eat fruits and veggies, and all of those things. Definitely want to educate on managing exacerbations, and they need to minimize as many exacerbations as they can by doing all of the things we just talked about. We need to provide supplemental oxygen therapy when it makes sense. We got to educate all of them to get their vaccinations, because we know that having a compromised respiratory system is going to put them at a much higher risk for catching any foreign invader like bacteria, viruses, and those things, right? So we're going to get your pneumococcal, your influenza, your flu, your COVID, all of those vaccinations. We're going to recommend them for pulmonary rehabilitation to build up their lung tissue over time, and we're going to properly manage their exacerbations. We also want to educate the patients to get to the doctor right away, right? When they have COPD and a chronic condition like this, they need to make sure they don't try to fix it at home because it can lead to a really quick deteriorating patient. Medications to treat COPD includes bronchodilators. We talked about it on the other video. Meter dose inhalers, we talked about it on the other video. Medications that are given through those means are beta-adrenic agonists, anticholinergics, combination agents, corticosteroids, antibiotics, mucolytics, and antitussives, which we've discussed in the other video, and we're going to cover in class as well. Nursing management. Again, we discussed this thoroughly in the video, and we will be practicing it in class with our case studies. We're going to be assessing the patient's full medical history, health history. We're going to look at diagnostic tests. We're going to look at pulmonary function tests if the doctor orders them, because it'll tell us how well they're able to clear their airway. We're going to look to improve their breathing patterns, their activity tolerance. We're going to look to improve their activity tolerance over time, right? That's something that's going to take time to improve, but we will take small strides toward that. We are also going to give them proper education on their meds, right? Whether it's a meter dose inhaler or what other meds they have. Okay, so bronchiectasis is a chronic irreversible dilations of the bronchioles and the bronchi. It's caused by airway obstruction and pulmonary infections, diffuse airway injuries. Some genetic disorders can lead to it. And sometimes we don't know the exact cause. That's what they call idiopathic, meaning they tried to narrow it down to one of these things, but they couldn't determine what the legitimate cause was, right? So how are we going to manage it, and what is your patient going to look like, basically? So they're going to have a chronic cough, spirulent sputum in copious amounts, clubbing of the fingers, because when you have a ton of copious spirulent sputum, you're going to not get oxygenated to your tissues. And we know that the body feeds the core first with oxygen and all of the needed blood. And so your tissue most distal or further away from the core is going to be oxygenated last. Thus, patients end up with clubbing of the fingers, right? Because their tissues are not getting oxygenated. So they get the thickening at the end of their fingers called clubbing. You're going to get postural drainage. So the patient's going to need chest physiotherapy. They're definitely going to need to stop smoking, and hopefully they're not smoking. We're going to do antimicrobial therapy because we talked about how sputum will trap bacteria in that environment and grow. Bronchodilators and mucolytics, right? And push fluids. Fluids should be on that slide too, because we're gonna get rid of mucus, you need to thin out the secretions and make them easier to cough up. The way we do that is to have them drink water, right? Fluid. Got all those already. Oh, conserving energy. Very important, right? Because doing anything, including just eating, is going to take energy. They're not going to have. So we got to educate them on conserving energy and how to do that, right? And then early signs and symptoms of possible respiratory infections so they can get to the doctor quickly and get on antibiotics and other therapy. Okay, next is asthma. It is a chronic inflammatory disease of the airways that causes hyper-responsiveness, mucosal edema, and mucus production, right? Inflammation leads to chest tightness, wheezing, coughing, dyspnea. Asthma is largely reversible with treatment, and sometimes it will resolve on its own spontaneously. And again, usually with age. That's where they say they'll outgrow it. That's literally in the medical term, it's spontaneously resolved. And then allergens are the strongest predisposing factor and the number one cause of exacerbations. I would say right there with stress. Clinical manifestations of your asthma patient is going to be coughing, dyspnea, and wheezing. And that could be on a daily basis. But when they have exacerbations, they might have a productive cough and they may not, but their coughing's going to be way, way more, right? So they're going to be coughing more. Could be productive or not. Generalized wheezing is going to be significantly more. Chest tightness and dyspnea will now occur. They're going to be diaphoretic, tachycardic, right? Their heart's trying to compensate, it's working hard. Can end up with hypoxemia and cyanosis. So medications we're going to use to treat asthma attacks are going to be quick relief meds like the beta-2 adrenic agonist and the anticholinergics. And then the medications we're going to use every day to keep exacerbations at bay are corticosteroids, long-acting beta-2 adrenic agonist, and leukotriene modifiers, okay? We're going to talk more in depth about these in class. We're going to teach patients and asthmatics to identify what their triggers are, and they need to avoid them at all costs, right? We're going to also teach them about proper inhalation techniques, how to perform a peak flow monitoring. It's important that they do that too, right? So they can keep an asthma attack at bay, as if they can, right? How to implement an action plan when they start to see using their peak flow monitoring when they get in the yellow zone, right? So they can stop it before it gets to a red zone. And when and how to seek assistance, right? All of those things. We need to give them very detailed information about what to do with an asthma attack, right? Or what to do when they're using their peak flow monitoring and get to the yellow zone. A peak flow meter is a handheld device that measures how well the air moves out of a patient's lungs, right? During an asthma attack, the airways often narrow. A peak flow meter can measure this narrowing hours or even days before an asthma attack or symptoms happen. In fact, peak flow meters, evidence-based practice has shown that a peak flow meter is so sensitive to changes in a patient's airways that it can alert the patient a patient having breathing issues even better than a doctor can when listening to a patient's lungs with their stethoscope. So patients can use peak flow meters, and when they get to a yellow zone, they can take medications that a prescriber has provided for those symptoms, and therefore they can literally avoid a serious asthma episode that could potentially cause life-limiting, event, right? So a peak flow meter can tell them when they need, when they should call their doctor, what extra meds they can take, all of those things, right? And really, the peak flow meters are really inexpensive, and they measure literally the patient's ability to push air out of their lungs, and they will the patients will literally stand up, right? So how do they use a peak flow meter? I'm just going to tell you this real quick. So the patient stands up and they take a deep breath, and then they're going to place the meter in their mouth between their teeth, and they're going to close their lips around that mouthpiece. They want to make sure you tell them not to, don't let their tongue block the hole of the mouthpiece. They're going to literally blow as hard and as fast as they can for one single blow. They're going to write that number down. And if they cough or they make a mistake, they don't use that number. They need to do it again. And then after that, they need to immediately repeat that one more time and then they're going to write that number down. And then they want to use the highest they need to do that 3 times and use the highest number. And that's their number for their asthma diary that you're going to tell them to take. And then that'll guide them with the red, yellow, and green zones, right? Red, yellow, and green zones. So the specific color tells them what they should do, and doctors will give them orders, or providers will give them orders according to, if they're in the green zone, yellow zone, or red zone, right? It's important that patients recognize changes that are occurring daily as they manage their asthma. So no need to memorize any of, what the red zone consists of, what the pink, green zone, I said pink, that's hilarious. There's no pink zone. It's green, yellow, and red. And each provider may alter those levels anyway. Like if they have a patient whose asthma is more sensitive, they may change, the zone and make it a smaller range so that they're better managed, right? So that's why we don't memorize that. Just know, though, when patients are in each of those zones, what that means, right? Okay, patient teaching, obviously. Green zone is when they've got about 80% of their lung function, right? So they're using their meds and therapy, and they're doing things they should be doing. They're staying in that green zone. That's a good zone, right? Now, when they get to the yellow zone on their peak flow meter, that means they're anywhere between, 50 to 80%. I always look at the bottom number, so I'm thinking 50% of my patient's lung function tells me they're going to be using more of their bronchodilators or rescue inhalers. So that's a problem, right? So then physicians will usually have their patients call into the office and speak to the nurse, and we'll give them additional directions. Or if they are other providers may give them add this medication if you end up getting into a yellow zone. And then of course, red zones are emergencies. That is a no mess, no fuss. You need, like, red equals dead, like get immediately taken care of, right? So again, we're going to educate our patients how to implement action plans that the doctor puts in place and the team puts in place as they start, in the yellow zone and so forth. And then, of course, when to seek out medical help. Some risk factors for COPD patients: exposure to any tobacco smoke will definitely exacerbate their condition. We know older adults, right, because of the multifactorial pieces of what happens with the organs in the body deteriorating over time, right, can put them at a higher risk for a COPD exacerbation. We talked about occupational exposures in detail. Pollution we talked about in detail, and then we mentioned the genetic abnormalities with having COPD. So when we say genetic COPD components, we're talking about a trait was passed on from their parents that contributes to or causes COPD, right? So many genetic variants that, there are many genetic variants that increase a person's risk of COPD. Many of those have been identified, right? But alpha 1 antitrypsin deficiency is the most well-known and steady genetic contribution to patients who are predisposed to COPD. And that is the one that you will need to know for NCLEX, right? Again, it's alpha-1 antitrypsin deficiency. It's a protein that's made in our liver that's responsible for the protection of our lungs. So when the body doesn't make enough of this protein, when patients inhale smoke or pollutants or dust or smog or etc., that damages their lungs more easily and increases their risk of developing COPD, right? In fact, alpha-1 antitrypsin deficiency is likely responsible for a significant amount of someone's COPD if they have it. And it is possible to have an alpha-1 antitrypsin deficiency without them knowing it, right? So if patients have a family history of this deficiency, then this diagnosis can definitely protect their health, right? So if they do have that genetic predisposition of the alpha-1 antitrypsin deficiency, then they're typically diagnosed with COPD much earlier, like around the age of 40. The age of 20. So when you have the alpha-1 antitrypsin deficiency, you may see patients begin shortness of breath and wheezing, and they can begin as early in their 20s, right? And then they may also have an asthma diagnosis with that deficiency, and the extent of lung involvement may be more. And these are patients that don't have a history of smoking. They don't have a history of working in industries where it exposes them to variants that can damage lung tissue, right? So those are all things that tells a doctor or prescriber, okay, I need to check the liver to see if, it's not producing that protein, right? That protects the liver. So, that protects the lungs. That's made in the liver. So that's the piece about the genetic abnormalities, okay? So nursing care for patients with COPD, we're looking at obviously evaluating what irritants or situations will exacerbate them, helping them figure that out, right? We do things like educate on incentive spirometer to help promote oxygenation, postural drainage, chest percussion and vibration, things they can do at home, breathing exercises they can do at home, right? The meds that they're going to be taking, including oxygen, right? And the fact that, remember, because a COPD patient is a carbon dioxide retainer and their drive to breathe is we don't want to knock out their drive to breathe by allowing them to turn up the oxygen really high, right? So that's why we encourage and educate our patients who have CPOD to try to keep the liter flow on their concentrators at about 4 liters, right? And then how to use bronchodilators as well as the long-term meds like corticosteroids and things like that to keep exacerbations at a standstill. Okay, so this is techniques that you can use to help support your patient while they cough. D is a good one because you want to show the patient how to provide support if they have an abdominal incision before coughing. If a patient is ever going to dehiss or eviscerate a wound, it'll be when they have an abdominal surgery and they don't splint that area when they go to cough. That is exactly how they end up busting open that area. So again, education for smoking cessation, making sure they take their meds correctly, the different breathing exercises, how important regular exercise is, realistic goals, and what they do when they get into the emergency management of it, right? Here's another picture of meter dose inhalers, dry powder inhalers, your spacer, and an albuterol inhaler or a meter dose inhaler. So we talked about oxygen therapy in detail in lab, right? Room air outside in the environment here is 21%, right? And by giving oxygen therapy, it does decrease the patient's work of breathing as well as the stress on the heart, right? When a patient's hypoxemic, that means they have a decrease in their arterial oxygen in the blood. Hypoxia is the decrease in oxygen supply to the tissues and cells. And severe hypoxia, as we all know, can be very life-threatening and life-limiting, right? Now, you also need to realize that patients can become toxic from oxygen. It is a med, and therefore, that's why we don't just jump to a non-rebreather unless it's an emergent situation, right? It's another reason we don't allow other interventions where we, just put oxygen on anybody. Because again, it's a medication and can cause toxicity. So again, oxygen toxicity can occur when we have too high concentration of oxygen for extended periods of time, right? And the symptoms include you have a patient who has respiratory difficulty, fatigue, malaise, restlessness, dyspnea, paresthesia. They could have chest discomfort. And then it progresses where they're literally having progressive respiratory difficulties. Then we call that refractory hypoxemia. They will have, the lung tissue will start collapsing. They may have atelectasis. They may have the full-blown lung collapse, right? And they may have infiltrates, and that can be seen on an x-ray, right? How do we prevent this from happening? Well, we need to use the lowest amount of oxygen feasible for that patient situation, right? We need to, if the patient's on a ventilator, we need to make sure that our settings, our PEEP settings, and are all set correctly. If they're on a CPAP machine, we can put a patient on a CPAP machine to reverse atelectasis as well as lower the percentages that are able to be used, right? So some things that we can do to definitely improve our patient outcomes for sure, right? Again, when you're doing oxygen administration, if possible, you want to start with nasal cannula, starts at 1 liter, and then go up from there. If they need 6 or more liters, then we transition to a mask and so forth. Kind of like what we talked about in lab when we discussed oxygen therapy, right? Let me see. We talked about all that already. And we talked about those already. Home oxygen. So we definitely are going to educate our patients about home oxygen therapy. We're going to have to be able to explain how to use a concentrator, all of the things that goes along with that, safe methods. We talked pretty thoroughly about this in the other recording, right? No smoking, don't use petroleum jelly, all of those things, right? Oxygen can be, again, you have oxygen tanks that sometimes are gas, liquid, or concentration of, and then they're portable. So your patients who have COPD can still go shopping and they can still go out for lunch and all of those things, right? Portable oxygen devices are a must. And remember, the higher the oxygen flow, we need to add humidity to that. We need to add moistness because we know with oxygen therapy, it dries out your nasal passages, right? And your mucosa. And then of course, community resources to help them in any possible way that we can. And we're going to do some case studies in class, make sure that we understand emphysema, chronic bronchitis, and asthma very thoroughly, be able to distinguish questions on an exam, more importantly, be able to care for our patients appropriately, right? Okay, this is the end of this chapter.